Dr. Amdekar is again the speaker for today's session as usual. He is a practicing pediatrician for last 50 years. He is currently the visiting consultant to SRCC Hospital, Mumbai. He has been the faculty to Grand Medical College, JJ Group of Hospitals, and Institute of Child Health, Mumbai. He has been the past president of IAP as well. Before handing over the platform to Dr. Amdekar, there is a good news that on popular demand and as requested by many of you in our WhatsApp group to continue the series. So we requested Dr. Amdekar and he has kindly agreed to do so despite his very busy schedule. Till now, we have focused on symptoms in the last series, and in the new series, we will be focusing on physical findings. Details will be announced soon in our WhatsApp group. So please join the group, those who have not done so far. So over to you, Dr. Ambedkar, sir.
Thank you very much, Anupam. I'm sorry for that it was unusual, but we are lucky we have got over it. Today we are going to talk about a very vague symptom, and that is the generalized weakness. Can I have the next slide, please? I think this is a symptom which is very much misinterpreted by many patients, many parents. And today's focus is largely on older children and adults, as usual. And I'm going to address mostly the adult problems or much older children problem and not a young infants and toddlers. I think this is a term which is often used by patients who are not gaining weight well, they're not feeling well, they're feeling tired. But occasionally the weakness medically might mean even a neurological weakness, which means there is a loss of power. And one has to be very, very careful. If there is a mild loss of power, then the patient may not know that his power is less. Only he may feel that I'm not able to do something which normally I do. And he calls it as a tiredness. I think the challenge is when this is the only symptom. Now, many times there are other symptoms in which the patient feels he is tired, but that is not difficult to make out. Today, we are going to focus on a symptom where there is no other symptoms whatsoever. And I think by tiredness generally is what general weakness means. One has to, of course, be sure that there is no loss of power. But when I am tired, I know it's my muscles which are tired. So first take a note that generalized weakness refers to tired muscles. And what do the muscles need to be active and not remain tired? Of course, they need oxygen. And don't forget, oxygen is produced by lungs. It's transported by hemoglobin to all the tissues. And all this is driven by the heart. So don't forget that the chronic lung disorders, chronic anemia, and chronic cardiac disorders may present initially just as generalized weakness, and one misses a small clue somewhere or the other, we are likely to just give them tonics and send them back, and we might make a mistake. Another thing that muscles need, of course, is glucose, and we will discuss about this in case scenarios. And of course, you need intracellular ions like potassium largely, and to some extent magnesium. And therefore, take a note, if a muscle is not supplied by enough oxygen through lungs, through hemoglobin, through heart, or if the muscle doesn't have enough glucose to work on, or if the muscle doesn't have enough potassium largely or magnesium, then your muscles are going to be tired. And this is what happens when you exert a lot, but within a short time of 5-10 minutes, you come back to your muscle. This is not weakness we are referring to. Having given this kind of an introduction, let me get the next slide, please. Now, this is your interaction. Which of the following statement is wrong? Generalized weakness may result from chronic hypoxia, chronic anemia, hypoglycemia, and hypokalemia. Which of these four choices is wrong? Your time starts now. Yes. Can I have the slide back again? Most of you thought that it was not chronic hypoxia, nor many more members in favor of any chronic anemia. Actually, chronic hypoxia, chronic anemia, and hypokalemia are the causes of generalized weakness, but not hypoglycemia. And I wanted to bring this point very clear to you that while lack of oxygen, lack of hemoglobin, lack of potassium all cause muscle tiredness, why should low glucose not cause it? Contrary to that, it's the hyperglycemia that causes muscle weakness. Look at this fun. When you have a lot of glucose, your muscles are feeling weak. Why? Because you have a diabetes, which means in spite of a high blood glucose in the blood, the muscles cannot take up this glucose. So muscles are hypoglycemic, but your blood glucose is very high. That's how diabetes starts with feeling generalized weakness. But why not hypoglycemia per se? When your blood sugar goes down, the body has a mechanism of storage of glucose from the liver, and the body pushes that extra glucose into the blood and prevents the muscle tiredness of hypoglycemia. But if the hypoglycemia is severe and the body cannot compensate for it, then the child becomes drowsy, unconscious, and even gets a convulsion. So take a note, hypoglycemia is often acute because the storage takes care of the immediate needs. But when storage fails to meet the demands, you suddenly crash. And hypoglycemia is an acute event, whereas really it's a hyperglycemia, diabetes, which presents with weakness. I wanted you to kind of keep a note of this very well. And a slowly oncoming diabetes patient may only come with general weakness and nothing else. Can you have the next slide, please? Now, the next slide shows a common causes, and I've already said you, chronic interstitial lung disease, where the problem is only hypoxia coming. There are often no respiratory symptoms whatsoever. You easily miss it when a patient comes with generalized tiredness or muscle weakness. Chronic anemia does the same. Chronic myocardial dysfunction, like a cardiomyopathy or some of the cardiac disorders which come slowly. The acute MI comes up suddenly. Therefore, you suddenly crash. Or when you have an angina, you only get some pain and it's transient. But when you have a progressive myocardial dysfunction, you only start with general weakness, and there are subtle symptoms and signs which are very easy to miss. Diabetes, I did mention about. Of course, chronic hypokalemia or hypomagnesemia is usually due to a chronic renal or a metabolic disorder, and therefore there is often a clue to a probable hypokalemia or hypomagnesemia. And don't forget, many chronic diseases like infections, malignancies, okay, or organ dysfunctions may present with just general weakness, and you might overlook some of the point. Like a chronic liver disease, unless you palpate the large liver, you will not know by the history. The patient may come only saying that he's feeling weak nowadays. He may not have jaundice, and therefore, chronic problems also may present initially with general weakness, but of course, there are some clues on history as well as, of course, on clinical finding. Having given this idea, can I have the next slide, please? Now, how do you approach this? First is rule out it's not a neurological weakness. And it's easy. Can the patient move all the limbs well? Yes. But don't forget that hypokalemia also causes neuroparalysis only when it's extreme. So, when there is a paralysis, one cause could be hypokalemia, but today we are discussing early stage of hypokalemia, and that comes only with tiredness or muscle or general weakness. Onset is very important because most of the conditions causing a generalized weakness are acute, are chronic, except diabetes in children, older children, often comes acutely. Okay. Acute renal disorders causing hypokalemia are not common, and therefore, I would say that generally the onset of a generalized weakness is subacute of chronic and not acute, exception that I mentioned. Progress is important. Most of them progress very slowly, like the respiratory causes. Often there may be only mild cough or low cough, chronic cardiac problem where there may not be palpitation, and chronic anemia, which is often easily missed. And of course, physical examination, you need to look at very, very important points, the respiratory rate and heart rate. Don't forget that chronic respiratory problem like chronic interstitial lung disease presents with generalized weakness, and the only clue is a very mild rise in the basal respiratory rate. Unless you count the respiration per minute, you will easily miss the respiratory rate. Same is true about a slowly progressive chronic cardiac disease, where the initial clinical findings could be a mildly increased resting heart rate, and often we miss it. Pallor is not easy to miss. I'm sure even the patients know it, but it is based just by looking at the palms and looking at the creases. And we have done this when we have discussed pallor earlier. Of course, look at the clubbing of the nails, which tells you there is a possibly a hypoxic condition, either a chronic lung disease or even earlier cyanotic heart disease, where mild cyanosis is easily missed. The next important thing beyond respiratory rate and heart rate is weight and height, growth. And of course, the body posture, hypotonia indicates very likely a hypokalemia. And keep this in mind. Important point on clinical examination of a patient to present with vague general weakness is a good 1 minute counting of respiratory and heart rate. It often gives you a possible diagnosis which is easily missed. And once this is clear to all of you, let's, as usual, do our 8 cases of different types of patients who may present to you with a generalized weakness. Can I have the next slide, please? So, this is your first case. This was a 15-year-old healthy child. Again, this problem represents even a young, healthy adult. But I have seen this 15-year-old, so I have put up my actual live cases. There are no virtual cases in our discussion at all. So this healthy child presented with feeling weak off and on for the last few months. And there were no other symptoms at all. Physical examination showed that he was very healthy, weight, height were fine, blood pressure was 150 by 85, and there were no other abnormality at all. Make a note, there is a hypertension coming up in this guy, but he's asymptomatic. Why is he asymptomatic? It's slowly coming up. Acute hypertension presents. A slowly coming hypertension may just present with something like just weakness. And now your options are, is it a functional disorder? Is it systemic hypertension? Is it chronic interstitial lung disease? Or is it a chronic renal disease with hypertension? Your time starts now. Excellent. Most of you have picked up rightly that it is possibly a slowly progressive hypertension. Okay, very good. Now, there are two probabilities. Is it a systemic hypertension like a typical adult hypertension, or is this a renal hypertension? What is the point against renal hypertension? He is a healthy child. A renal hypertension is a chronic nephritis and not acute nephritis. Acute nephritis does have a hypertension, but he's sick with edema, hematuria, oliguria. A chronic nephritis may not have obviously oliguria, hematuria, that is easy to miss, but that hypertension, because of chronicity, the patient does not remain healthy. In fact, this was, I did not want to put his weight and height. He was an obese child, already susceptible to hypertension. And don't forget that adult systemic hypertension starts in late childhood, which is a borderline hypertension. Sometimes in an obese child, it becomes even more severe, like in this child. And the only symptom could be an initial just feeling weak and nothing more. Good. But you all picked up hypertension, and I'm very happy about that. Can I have the next slide, please? The next case talks about a healthy middle-aged adult. He presented with gradually increasing generalized weakness over the last few months. And there were no other symptoms again. Today, I've picked up general weakness only as an isolated symptom, because that's the challenge. When a person of malignancy is losing weight and becoming tired, okay, you can always spot out in a senior citizen a probable malignancy and start looking at it. Now, this child has only one symptom, but on examination, he's a healthy middle-aged adult. His heart rate is 78, his respiratory rate is 24, and rest of the examination is all normal. Your options are chronic infection, chronic interstitial lung disease, chronic renal disorder, or a psychological disorder. Your time starts now. I'm happy that most of you have ruled out chronic renal disorder totally, and most of you have also ruled out chronic infection. Can I have the slide back? And therefore, that only now leaves us to chronic interstitial lung disease and psychological disorder. I did tell you on a clinical approach that you have to look at respiratory rate and heart rate very, very closely. Look at this child's respiratory rate is 24, which to a healthy middle-aged adult is a little more. And how do you know also that? Look at the ratio between the heart rate and the respiratory rate, which normally is 1:4. Okay, this child's ratio suggests that the respiratory rate has gone a bit higher as compared to the heart rate. And look at this 78 versus 24. You will immediately would have picked up to say that, oh, this is certainly a heart rate which is reasonably close to normal, but a respiratory rate is a little higher than normal. This suggests that the problem is likely to be in the respiratory tract. But this child has no cough at all. So the anatomy of the lung disease is such where the cough is not a feature or not a prominent feature. And we have done this when we discuss cough very early in our series, that a Cough indicates an airway disease, but as the airway becomes narrow distally, like in bronchioles or further down into the interstitium, the cough almost disappears or very insignificant. And this child had a chronic interstitial lung disease. And when we did his pulse ox, it was already 92, much lower than expected, close to 98 or 100. Imagine a slowly progressive chronic interstitial lung disease presented with just general weakness. And these are real cases. What made me diagnose this? Just count the respiratory rate and heart rate properly and see how they go together in the same ratio or otherwise. And a higher respiratory rate as compared to an expected heart rate becomes a respiratory disease, right? Good. Can we have the next slide, please? The next is again a young adult who present with a history of low-grade fever off and on and general weakness for 2 months. Okay? Look at the symptom, low-grade fever off and on and general weakness. He has no other symptoms. But surely you have already spotted out that it's some low-grade infection possibly coming. But look at the examination. Heart rate was 110, respiratory rate was 22, blood pressure was reasonably fine, temperature was mildly raised, liver was 2 fingers palpable, firm, but not tender, hepatojugular reflux was negative. There were no other positive findings. Make a note of all this very carefully. Now, your probable diagnosis is chronic hepatitis, hepatic tuberculosis, pulmonary tuberculosis, or none of the above. Your time starts now. Well, I am quite impressed, but most of you have said hepatic tuberculosis. Okay, let's get back to the slide. Now, the you have already picked up tuberculosis. Very good. There is no question. The most common cause of a low-grade fever off and on for last 2 months in our epidemiology is tuberculosis. Now, most of you thought that if this is tuberculosis, then it must be a liver disease because your liver is enlarged. Okay, but you forgot to again take a note of a heart rate and respiratory rate. Look at this heart rate as compared to the respiratory rate, which is reasonably normal. After all, 22 is a little high, but for this fever, it's fine. But the heart rate should have been 4 times more, maybe 88, 90, but it's 110. What does it tell you? It's a heart disease. But if it's a heart disease, then is the liver a cardiac failure? Make a note, chronic cardiac failure may not be a tender liver. An acute cardiac failure is a tender liver. So this is a chronic problem. So could it be a chronic cardiac failure? But if that was so, there would have been other auscultatory findings. And more important, hepatojugular reflux would have been positive if it was a cardiac failure. What does hepatojugular reflux negative means? That there is an obstruction to the inferior vena cava and superior vena cava. That's why when you press the liver, the blood column cannot go up because there is an obstruction. Now, tag the two things together. You have a heart disease as evident by an abnormally tachycardia presenting, and you have an inferior vena cava obstruction. I think the diagnosis is a constrictive pericarditis due to tuberculosis. I wanted to bring you this patient especially because these are real virtual, they are real patient, not virtual. When you die, when you look at the large liver, don't forget to look at the possible neck veins. And if the neck veins are there, then look at the hepatojugular reflux. If that is negative, you have diagnosed inferior vena cava obstruction, and the neck veins tell you superior vena cava obstruction. When both the vena cava are obstructed, the commonest cause is a constrictive pericarditis. And in our epidemiology, constrictive pericarditis presents as tuberculous constrictive pericarditis is more likely. And this was another example when a child of tuberculosis sure came with only general weakness, and they were very confusing finding. Time and again in our series, I have said that I am aware those of you who attend this seminar are all ready to keep on updating your knowledge. And that's why I like to bring also some of the less common, complicated, but clinically possibly diagnosable condition. And even if you pick this up as a heart disease because the heart rate was much faster than the respiratory rate, I think you would have picked up that, right? Let's have the next slide, please. The next slide is again a young adult who presented with general weakness over last few months, something similar to the previous one. But prior to onset, he was very active tennis player. But gradually, his performance started going down. And his coach used to always shout at him why he was not playing well. Take a note, slowly progressive weakness coming up, which he cannot now play well. Physical examination showed heart rate 100, respiratory rate 20. At rest, no cardiomegaly, but there was a mid-diastolic murmur at the mitral area. P2 was loud. What is your probable diagnosis? Is it chronic myocarditis? Is it a functional murmur? Is it a mitral stenosis? Or is it mitral regurgitation? Your time starts now. Wonderful. I think you all got the diagnosis right. Okay. Because it was a gradually progressive disorder with a mid-diastolic murmur, had it been acute, had it been chronic myocarditis, there would have been a cardiomegaly. This cell does not have a cardiomegaly. If it was a mitral regurg, there would have been a cardiomegaly and there would have been a pansystolic murmur. But in mitral stenosis, it's only the right sided of heart which is getting congested, and therefore the right ventricle enlarges. And don't forget, right ventricle is placed inferiorly and not laterally. If you look at a chest x-ray, the right border of the heart is the right atrium, and the left border of the heart is the left ventricle, and the right ventricle is inferior. That's why in many right ventricular hypertrophy, you get an epigastric pulsations, but the heart looks normal. I'm happy that you all picked up 100 heart rate against respiratory rate 20, primary heart disease, and you picked up a mitral stenosis. Good. Can I have the next slide, please? The next slide, please. Next slide, please. A young adult presented with increasing generalized weakness in the last few months. His appetite is good. His urine is plenty. Look at the physical examination. Heart rate 90, respiratory rate 25. He is dehydrated. He is lethargic. Your options are diabetes mellitus, diabetes insipidus, dehydration due to hot weather, or any of the above. Your time starts now. Excellent. I think almost all of you are getting the right answer. Okay. Uh, Look at the slide, please. It's a slide. Back to slide. Now look at this story correctly. First is heart rate and respiratory rate are reasonably close. Okay. A bit more of a respiratory rate. Normally 1 to 4. You could have expected heart rate to be 100. So take a note that there is a slight increase in respiratory rate in a child who is dehydrated. Now, if the dehydration was to cause increase in respiratory rate, also it would cause proportionate increase in heart rate. But this child has a little more respiratory rate as compared to heart rate, and therefore there is something happening with an increased respiratory rate. He is lethargic. That means his brain is also getting involved. Could it be only hot weather? If it was hot weather, there was no reason why respiration was a little higher. And this indicates that this could be an oncoming metabolic acidosis. Metabolic acidosis comes with rapid respiration and deep respiration. Okay, this is an onset of a metabolic diabetic ketoacidosis. He is dehydrated in spite of passing lot of urine. A child of a hot weather gets dehydrated, but also urine is also low in volume. Here is a child who has got a plenty of urine, and even then he is dehydrated. That rules out hot weather. Diabetes insipidus child would not have a mild rise in respiratory rate and would have been irritable more than lethargic because of hypernatremia resulting by a lot of loss of water. So diabetes insipidus would have come with hyperirritability, and diabetes mellitus with lethargy, hot weather with oliguria and dehydration, while diabetes mellitus with plenty of urine and dehydration, with a mild metabolic acidosis, and therefore, how small little thing that. Now, such examples will tell you that how a good clinician looks at every small point, and most important is the pulse rate and respiratory rate. Okay, we often don't look at them very closely. We just bypass them. Okay, and if you bypass them, you might end up with such a mess, such a simple thing which we often forget. And I think I wanted to get some such cases so that we are all aware of how simple bedside skills can make us diagnose majority of the conditions. And I think that is important. Can I have the next slide, please? The next slide, please. Now, here was an 8-year-old child. I wanted to bring one more condition because it's not so common in adults, but often also seen in adults. Okay. Now, this was an 8-year-old child who presented with generalized weakness. He had a poor appetite. He had lost 2 kilos. He had an excessive thirst since last few months. He was irritable. There were no other findings. Your probable diagnosis is diabetes mellitus diabetes insipidus, any of the above, or none of the above. Your time starts now. Excellent. Almost all of you have got the right answer. Some of them have said maybe any of the above. Can I have the slide back again? Take a note that he's irritable, he has lost weight, he has a poor appetite. So he has certainly a chronic progressive disorder. And excessive thirst obviously means he's polyuric. That's why he's wanting to drink more water. But what I wanted to bring to your notice this is that though diabetes insipidus by per se is not so common in adults, but and adults may present with pituitary tumors in which the only symptom could be polyuria and general weakness. Of course, such a symptom of a pituitary tumor could also bring in some headache, vomiting, etc. In children, often that could be a pituitary dysfunction even without a tumor. Therefore, I've seen this child without a tumor, but even an 8-year-old can have tumor. And don't forget that if a tumor is small enough, it may not present with headache, vomiting, but it may present with only a pituitary dysfunction. And depending on which area of the pituitary the tumor rests on, if it's a posterior pituitary, the only findings could be a polyuria and no other involvement of anterior pituitary, like a thyroid, adrenal growth, etc. And therefore, even in adults, this is possible. A pituitary tumor or a hypothalamic pituitary tumor, if it's small enough, it may just present with polyuria. And I did not want to give you polyuria here, but I wanted to give you excessive thirst, which is almost suggestive that he is losing a lot of water. Patient may complain he's very thirsty, and when you ask, he may say, yes, I pass a lot of urine. A child who passes a lot of urine and is thirsty is polyuric, whereas a child who is excessively thirsty but passing less urine is hypovolemic, dehydrated, maybe whatever the cause. So I wanted to bring this point because a hypothalamic pituitary tumor may present only with general weakness and polyuria hiding behind it as an excessive thirst. Can I have the next slide, please? The next slide is again a middle-aged adult who present with general weakness since last 2 months. He had a history of COVID infection 6 months ago. Look at his physical examination. He has a heart rate 100, respiratory rate 20. His blood pressure is a little on the lower side, systolic 105, 18. What is your probable diagnosis? Chronic interstitial lung disease, chronic heart disease, chronic renal disease, or diabetes mellitus. Your time starts now. Majority of you have favored chronic interstitial lung disease, but there are others also pitching in, but all of you have almost ruled out a chronic renal disease. Please get back to the slide, please. Now, look at very carefully. This child has had a COVID infection in the past 6 months. And look at again the heart and respiratory rate ratio. Heart rate is faster than expected, which means that this is likely to be a heart disease. Take a note of that. If it was a chronic interstitial lung disease, disproportionately the respiratory rate would have been higher. I want to stress on you the importance of heart rate and respiratory rate when you have no other symptom and no other sign to go by. And imagine in all these cases that we have discussed so far, it's a heart rate respiratory rate combination that has told you where is the anatomy of the disease. So this obviously is the heart problem. And look at the blood pressure, which is little on the lower side, which means myocardium is not doing well. And friends, you may have seen more often than what I have seen in pediatric age group, but today a post-COVID complication come up even after few months, and largely the complications could involve heart, lung, or even the brain. And they come up very subtly, they come up very slowly, and they go on worsening over time, or if you're lucky, they may even get better. Today's COVID infection has taught us that there are likely to be subtle complications coming up slowly even after a complete recovery of a COVID infection naturally without any immediate complication. This is one example of a late complication of a COVID infection. But point is not only that, point is pick up a little increased heart rate and pick up a little low blood pressure. Two put together, it becomes a chronic myocardial disease. Let's have a last case. The last case, can I have the next case, please? Next case, yes. This was a young child again. Again, this problem is not rare in adults, but far more in common in children. Today we see this very commonly. 4-year-old child presented with general weakness, poor appetite, and weight since the age of 1 year. Okay. From 1 year of age, these problems are there. He is happy and active. He's 12 kilo at 4 years. Surely his weight is low. His height is 97, which is all right for 4-year-old. He's only mildly pale. He has no other abnormality. This may also happen in an adult, but many such adults may not even come to a doctor. But when it happens to a child, the child always is brought by parents to a doctor. That's why I brought this child. But even in adults will have the same presentation. Your probable diagnosis is chronic anemia, chronic interstitial lung disease, chronic TB, or a normal child. Your time starts now. Well, very few of us have chosen other three things, but most of you thought it was a chronic anemia. Can I have the slide back, please? Now, remember that there is the mild pallor. Mild pallor never causes symptoms. Even a moderate pallor doesn't cause a symptom other than just showing pallor. But when the pallor becomes severe, you start feeling weak. Mild pallor doesn't make you feel weak. Okay. So, this is not chronic anemia. Again, if it's going on for 3 years, since the age of 1 year, it's not a progressive anemia. So, obviously, it is not chronic interstitial lung disease. It's not chronic TB. Point I was making is a normal person definition is, which is true for adults also. A normal adult is not considered by his weight, but by his height, which represents growth, and more important, by health. And what is a definition of health? Happy and active. Many adults, I'm sure you must be seeing, who are thin, who may mostly have a normal height or a mildly subnormal height, but are very active and happy. That is a sign of health. And health is measured by not weight. Of course, the weight should not be going down, but weight may not go up. There are thin and very fit people, adults. You know, fat are not often fit. Two F's can't go together. So I wanted to bring forth many times when an adult also imagine he's a little thin. Somebody may say, just go to a better doctor. Why are you so weak? Thinness is not weakness. Activity and energy and happiness is what health is. And I just wanted to bring you this point. Can I have the next slide, please? Now, last interaction for you. When a physical examination is normal in a patient to present with generalized weakness, which of the following clues guide relevant investigation? Disproportionate heart rate, respiratory rate, general appearance happy or sick, urine output and appetite, and all of the above. Your time starts now. Wonderful. What an end of today's session nearly. And also it happens to be end of this series, but I have promised to continue another series based on only the physical examination finding. Okay. I will just end up with last take home message. Confirm what the patient means by generalized weakness. Okay. It may be neurological. And don't forget, hypokalemia in an initial stage comes as generalized weakness, but if hypokalemia is not treated, then you become even paralytic. So rule out neurological disorder. Detailed history offers a clue. And observe closely subtle abnormalities that are easily missed. What are the subtle abnormalities? In a previous slide, you all unanimously said heart rate, respiratory rate, healthy or sick, mix important, and appetite and urine output. Don't forget to ask these three things in every patient who comes to your clinic, whether he has general weakness or no weakness. I wanted to stress a point that if you are asked to look at only three factors in history and examination of a patient, you would look at only these three: heart rate, respiratory rate, healthy or sick, and appetite or urine output. You will almost make a diagnosis. Dr. Anupam, I'm sorry I was a bit problematic on sound issue. That's where we started late, but I'm happy we could almost finish the last seminar of this series in a very positive note. All attendees got the right answer. I think we are progressing right. If you have some time left and if you have some questions, I'm ready to answer.
I'll take just few questions, not more, because we have already started late. Very interesting questions are coming on. Can hypokalemia be suspected clinically?
Yes, hypokalemia in a muscle tiredness and general weakness. Look at the heart rate. It is often bradycardia, because even myocardium is a muscle, and if your resting heart rate is 70 of your patient, then he's beating now at 60. While if he's feeling tired, he should be beating more. He's beating less. Bradycardia, slight, and also a bit of abdominal distension, because intestines are the other muscles which become hypotonic, and you have a little distended abdomen. So don't forget, when you have a muscles which are tired, there are two other muscles in the body, intestinal muscle and a myocardium, heart muscle. They also start feeling weak. And take a note of this, you might easily pick up something going wrong.
Another question is, can interstitial lung disease present without cough?
Yes, I told you that cough is a feature of an airway disease, and as the airway becomes smaller in diameter and extremely small in diameter, the patient cannot get the required pressure to be built up in the airways to be able to cough. What is cough? Okay, something irritating. Therefore, when you cough, you first take a deep inspiration, fill the whole airway with enough air, and then start exhalation, close the glottis, and increase the pressure of the airway so that suddenly the glottis opens and a cough results. So, cough needs a building up of a airway pressure. When the airways become extremely narrowed down, almost to the bronchioles or the interstitium, you cannot generate so much of pressure. So often there may be no cough at all. Or when you ask the patient, do you have cough? He said, no, no, occasionally little cough. Insignificant or absence of cough is quite a feature of bronchiolitis or a lung disease, interstitial lung disease. And that's why general weakness of a chronic interstitial disease may come even without cough.
Another question is, why does chronic anemia present as generalized weakness?
Come back again.
Why does chronic anemia present as generalized weakness?
Oh, what happens with chronic anemia is that there is not enough hemoglobin to carry enough oxygen. So the hemoglobin could be not properly saturated. So imagine if hemoglobin is carrying only 20% of our available oxygen, then because there is not enough hemoglobin, there may be enough oxygen. So imagine a manufacturing site has enough of the equipment or enough of the products, but the lorry is not there, large lorry is not there, only a small tempo is there. How can the product reach the market with a small tempo when you needed a large, big size lorry to take it to the market? So if hemoglobin is not enough, there is enough oxygen, but there is not enough binding agent to carry. And if there is, that's why a slowly progressive chronic anemia starts with only a muscle weakness, and that is tiredness, but not a mild or a moderate anemia.
I think a lot many questions are coming in. Let me take just one last question. Rest
Sure.
we will cover in GP clinics.
Sure.
So, what is chronic fatigue syndrome and burning feet syndrome?
Chronic fatigue syndrome and burning feet syndrome are largely coming from not the muscles or not the soul which is burning, but coming from the mind. Friends, remember there are two things in body. One are all organs which are visible by history, visible by physical examination, visible by investigation, visible by imaging. But there are few organs which are not easily visible. And only two organs, to my mind, are not easily visible. One is the immune system and adrenals. Okay, they are not easily visible, even by imaging. Special tests maybe. But one organ in the body which is totally invisible for symptoms, for science, for even laboratory tests or imaging is the mind. And mind is often the seat of a disease. All such disorders that we are talking about could also be due to some changes in the autonomic nervous system or some changes in the peripheral nervous system. But there may be other clues as well. But if there are no clues whatsoever, then there are often in the mind. So I feel tired in the mind, not really in my body. For example, many children complain they can't go to the market and help the mother but they are able to go and play outside. So, mind is involved. Of course, you may have to rule out every other possibility before labeling it to mind, and such problem may arise out of a peripheral neurological symptom as well. But there are often other clues.
So that we are coming close to this end of the series. And I would request Dr. Amdekar sir, would you like to say a few words on this series being concluded today?
Yeah.
Doctor, as we are coming close to this series, would you like to say a few words on this series being concluded?
Well, I have nothing more to say, Anupam. All that I have said is that I hope what we are doing is helpful to you. Please feel free to tell us what better way we can make you get what you want. I formulated all this series only to what I feel would be important to you. But I'm not sure whether there was something lacking that you may like to know. Anupam has told me that I should talk more about older children and adults preferably. And I'm sure I've been trying that in the last few of our webinars. And I promise to do that more so in terms of the next series. And I feel I am reasonably capable of doing it only because when I see as a pediatrician children up to 18 years of age, I also do see adult problems at 15 or 18 years of age, except problems in senior citizens, which I myself must have also experienced. I am 82-year-old. So I think I told Dr. Anupam that I am reasonably good enough, not the best enough, but good enough to start kind of sensitizing your thought process. And that's how I have agreed with Dr. Anupam's request that I should continue to look at the next series with a focus on older patients. Okay. And I will also talk a bit of very senior citizen when I talk about this. I hope that serves your purpose. But final request again, do let Dr. Anupam Agarwal know what more you expect out of us or what less that we have been talking about is good enough for you. Please be open. There is no insult at all. I will be very happy to know what I could do better, and I promise to do better. Thank you, Anupam, for all this opportunity.
Thank you very much, sir. You are not good enough. You are the best enough for us always. And it is a pleasure for us to have you all the time. So thank you, Dr. Amdekar, sir, for this wonderful session and the series being concluded today. We hope this interactive session would have made learning interesting for attending doctors to help empower their practice. On behalf of GP Clinics and DocIsLive.com, I thank all the doctors who have attended this session. Let me tell you that with each session passing by, more and more doctors have joined this session. And let's meet in our next series, second series to be started soon. We'll update about it in the WhatsApp group. Please join this group in large numbers. And also we'll be uploading the certificate for you to download from DocIsLive.com in next few days. All those who have attended all the sessions would be able to download the certificate of participation. So thank you very much, all the wonderful audience we had in our last 1 year. Thank you very much once again, all of you. Good day.
Good day to all of you.